Good morning, everyone. Today we are going to discuss about systemic vasculitis. So, to talk about systemic vasculitis, as you can see, systemic, you can say generalized all over, and vasculitis is like the inflammation of the vessels. So, by definition, systemic vasculitis. So, you can say like these are the group of disorders or diseases characterized by inflammation by inflammation and necrosis of blood vessel walls. Okay, so of course, like this thing is clear that these are the conditions in which there is inflammation of the vessels. That's what is called as vasculitis. And how we classify them, there is a criteria called as Chapel Hill criteria. But to make it easy, or to tell you more about that thing, is basically whenever there is necrosis of the blood vessels walls, so there are different sizes of vessels in our body. Like there are large size vessels, there is medium size vessels, there is small size vessels. So different conditions they damage or they affect the different type of vessels, and that's why there are different clinical features. So you can say there could be damage to the skin, to the heart, to the lungs, to the kidneys, to the brain, of course, like, and to GIT, or like all the other organs which are present in the body, of course, because the blood vessels are everywhere and all the organs or every part in the body depend on the blood supply. Uh, so so that's why, like, but what kind of damage it will give, each type of vasculitis depend on which kind of vasculitis is there, or depending on what is the size of the vessel which is inflamed. So simply, these conditions can be, you can say, um, mild type of conditions which affect like one organ, or they can be so severe or systemic that it can lead to multiple organ failure. And one concept again before discussing the conditions, vasculitis, okay, um, may be or classified as primary and secondary. Okay, so what we are going to discuss in this lecture is basically the primary type, because secondary can be secondary to multiple conditions, like um, it can be secondary to infections. Okay, it can be secondary to SLE, it can be secondary to rheumatoid arthritis, could be secondary to endocarditis. Okay, if you remember, in endocarditis there is, vascular phenomena, and then there is immunological phenomena. It could be infections, can be hepatitis B, hepatitis C, and all this one. So simply, it could be uh, secondary to many things. Okay, so, and whenever it is primary, of course, it is not in the presence of other condition. Rather, you can say about most of them we don't know what is the etiology of the thing. So the importance of this thing is what kind of vasculitis are there in the body, right? Uh, to explain you that thing, I can show you this diagram, and in this one you can see that large size vessel, then there's medium size vessel, then there is small. and small give arterioles, and then there is capillary walls, and then there is venules. You can see like they number it number one, and here they have written what GCA. GCA is giant cell arteritis, or we also call it as temporal arteritis. Now, uh, of course, it affects the large vessels, and then they talk about Takayasu's arteritis, and then like there is one more Behçet's disease. Okay, so now Behçet's disease, for example, it's a multi-system disorder, and it presents with ocular involvement, uveitis, as well as recurrent oral and genital ulcers, and they present with venous thrombosis, and they affect young people, mostly males. Okay, Takayasu's arthritis, again, it is also called as pulseless disease. Why? Because whenever the patients they affect by this thing, there is unequal peripheral pulses, and this is like in this one there is inflammation of the aorta. Aorta and its branches. So aorta is the biggest vessel in the body. And if you will see like the medium-sized vessels, they talk about the polyarteritis nodosa or Kawasaki disease. Now, we have already covered Kawasaki disease, if you remember, in pediatrics, right? And we covered that thing in quite a good detail, talking about its myocardial or cardiac abnormalities as well, complications. And third one, which is the small one, you can see they talk about here. They talk about GPA. Now, GPA is basically granulomatosis with polyangiitis. Granulomatosis with polyangiitis. So simply, there is granuloma formation, there is polyangiitis, like inflammation of multiple vessels. Previously, this condition is called as Wegener's granulomatosis, but nowadays they call it as GPA. And then they talk about Chwarg-Strauss syndrome. And the other name of this condition is eosinophilic granulomatosis with polyangiitis. You can say both of them, they are quite close. In this one, there is eosinophilia. And then they write over here microscopic polyangiitis. Okay. And that's why it is called as microscopic polyangiitis, because it affects the small vessels. And then there are many other causes of small vessel or small vasculitis, like we had covered one thing called as Hinox-Collian purpura in pediatrics. So Hinox-Collian purpura, which give that rash on the lower limbs, and like it is also called as IgA vasculitis, by the way. So these are the causes of vasculitis, right? Not just these, like of course there are many others, but what we are going to talk about is the important points about that thing. And now what we can talk about in this one is first of all, we know like it is the vessels. And okay, now you know what I'm going to do. I'm not going to take you in the detail of everything, because you can say they are not so important. So there are some typical clinical features for all the vasculitis. For example, clinical features, right? So what are the clinical features? Like all these vasculitis, you can say they give local tissue ischemia. Okay. Of course, whenever there is vessel inflammation, so the vessels are inflamed, so the blood cannot be supplied properly. So what will happen? Like there will be local tissue ischemia, right? And then there are some systemic effects of the inflammation. So you will see over here that systemic effects, for example, these patients present with fever, these patients present with weight loss, these patients present with fatigue, these patients present with rashes, okay, and things like this. So simply, of course, like depending on the tissue which is involved, there will be the clinical feature for that, and then there will be systemic clinical features. Okay, now whenever we go for diagnosis of this condition, first of all, we found that these are the patients who have multiple organ ischemias, or they have systemic evidence as systemic involvement as well, and we found these constitutional symptoms. And then what we do, like when we go for the lab investigations and we check like what kind of abnormality is there, either the ESR is raised or not, and then we can also go for biopsies just to see what kind of thing is there. Okay, so for example, uh, now the clinical features also depend on something, uh, depending on either the person is having large vessel ischemia vasculitis or medium vascular vasculitis or small vessel vasculitis, right? For example, uh, whenever anyone is infected or affected with small vessels vasculitis, uh, small vessel vasculitis, for example, I'm giving this example because of hinox squalene purpura, right, which affect the small vessels. So see what happened, like the small vessels, they become inflamed and they become leaky, so they will be having rash, or you can say non-blanchable rash, or what we can say is palpable purpura. Remember, when small one is are called as petechias and bigger one is called as purpuras. And now these are the patients who present with superficial ulcers. Why? Because the small vessels uh, are inflamed, so that's why they develop ulcers over there, and they develop chronic urticaria as well as vesicles. Okay, so these will be the features of small vessel vasculitis, and why they are occurring, because the small vessels in the body, they get inflamed. Okay, so uh, of course, like we cannot talk about all the conditions all together, and they are not important. Like as I told you, like even if we will talk about all the things, they are not going to help you anyways. So, for example, there is a condition called as Takayasu's arteritis, which I told you the first one. Uh, so this one is a large vessel vasculitis, right? Or simply the aorta is the one, or the branches of the aorta which are affected. Okay. Now, this one, Takayasu's arteritis, is very common in females, and Takayasu's Takayasu's arteritis, what happens that, like there is granulomatous inflammation. So what will happen? Like there are granuloma formations. So in the vessel wall there will be multiple granulomas. So due to that granulomas, what happens? The vessel wall, the vessel lumen become small or narrowed. And when the vessel lumen becomes small or narrowed, or it is occluded, what will happen? That first of all, the blood will not pass properly, and secondly, the part of the vessel wall where there is granulomatous inflammation, that become weakened. So now, of course, like they will present with the same things which I told you, the systemic features, like They will present with weakness or fever or malaise and weight loss, things like this. But as this one is the one which is affecting the large arteries like aorta and its branches, like brachial, radial, axillary, femoral, all these arteries. So when we examine them and we check the peripheral pulses, we found like there are unequal pulses in all the four limbs, which means that due to inflammation at multiple points, they present with this thing. So this is how it presents, and this condition is classified on four major types. Like type 1 is when it is localized to aorta, type 2 when it is localized to descending thoracic and abdominal aorta, type 3 is the combination of 1 and 2, and the type 4 is when it is involved with the pulmonary artery. So I'm talking about Takayasu arthritis. So guys, this is a primary type of arteritis. We don't know the cause. So that's why what we can give them is again high dose steroids or immunosuppressive drugs. Okay. Now I would like to talk about a few of the conditions in this lecture. The first one which I will be talking about is no, sorry, the second one, because Takayasu I already talked about. Okay, the small vessel, which was previously known as Wegener's, or nowadays it is called as granulomatous or granulomatosis with polyangiitis. Okay, so simply like there are granuloma formation, there is polyangiitis, and I told you previously it is called as Wegener's. Wegener's granulomatosis. Okay, so previously it was called as this thing, but nowadays it is called as granulomatosis with polyangiitis. Okay, again I will take the help from Bing and I will show you how it looks like. Okay, you can see like this photograph is given over here, right? And here they are showing you some pathology, and here they talk about what you can say, like they're talking about some respiratory system is affected. Okay, here they are again showing you some mouth ulcers with some skin findings. Okay, so see, what you are getting is multiple type of involvement, right? And you will find a lot of pathologies with finding on the lungs, right? Now the thing is granulomatosis with polyangiitis, or GPA. We also call it as ANCA, ANCA associated vasculitis. Okay, and you know what is ANCA? It's an autoantibody. So what happened is simply these are the patients who have granulomatosis, inflammation of the vessels. That, so you can say this is granulomatous inflammation of vessels that may affect. Now you would understand why I was talking about like they were showing the respiratory center and all this stuff. Upper airways. Okay, so what are upper airways? You know what are upper airways, right? The nose and all those things, and it can also affect the lungs. So that's why they were showing you that lungs imaging with pulmonary nodules and infiltrates, and as well as kidneys. Okay, so simply it gives glomerulonephritis and renal failure. Now, why we call it as ANCA associated? But because this is when we do the indirect immunofluorescence. Okay, what we found is C ANCA, And I discussed one in one of the lecture, what is C ANCA and what is P ANCA, right? So C ANCA, PR3 ANCA, simply. Uh, we found this thing in their body. And what happened, whenever the patients have this thing, of course, like they have granulomatosis vasculitis, right? So, um, and the type of kidney problem they give is basically focal segmental glomerulonephritis. So there is a criteria to diagnose this thing. For example, uh, anyone who have nasal or oral involvement, anyone who have abnormal findings on chest X-ray, anyone who have some urinary findings, and anyone who have biopsy findings. So see, that's why, like, I show you that Bing thing, and they were talking about, they show you biopsy, they show you the histology for what, like, for the kidney as well as the biopsy. Uh, they show you the chest imagings, and they show you the nasal and oral mucosa. So see, these four are the main things. And if anyone have any findings, like out like two, there are four things, right? So out of that four, if two are present, so we say that the patient have uh, granulomatosis with uh, polyangiitis, right? So now, what are the sign and symptoms, guys? They will remain same. These are the patients who will give some systemic features, like the same thing which I told you in the start, malaise, fever, weight loss, fatigue, all this stuff. And now, the local clinical features which will be present in these patients, clinical features which will be present in them is like they present with sinusitis and rhinitis, and sometimes with bloody nasal discharge. Why? Because there is granulomatosis going on. Okay, and many of these patients, they have saddle nose. Why saddle nose? Because of granuloma formation. The septal, or the septum of the nose, it get destroyed. Okay, so they have like the saddle nose deformity because of that. So what is the thing, like their uh, what you can say, their septal cartilage is destroyed, right, because of granulomatosis disease. So they may have this kind of abnormality. So this thing, now they may present with proptosis, simply because, like, there is an inflammation in the extraocular muscles and granuloma formations, which basically push the eyes outwards. Okay, and like the orbit is very close to the nasal area, so that's the reason, like, they may have proptosis. And many of them, they have hearing loss as well, of course, like due to AIDS cranial nerve involvement. And then they have pulmonary features, like they present with cough, they present with hemoptysis. They present with uh, on chest X-ray or on imaging. You can find the masses on imaging. And then they have renal involvement, as I told you. So renal involvement again comes with hematuria, because remember, it caused glomerulonephritis, proteinuria. So you have done this thing, and like what is hematuria, what is proteinuria, and all the other features of renal failure, like elevated urea and creatinine. And again, like other things, it can involve the joints, it can involve the skin, it can involve the eye, it can involve like the nerves. So whatever is there, of course, like these are clinical features. So simply, like, these are all the clinical features of glomerulonephritis. And again, like the diagnosis, of course, like you will found a lot of clinical things you will found, and then you will go for the blood workup, you will do CBC, you will found anemia in these patients, right? And they will be having increased So you can say it will present with anemia, with increased WBC's count. Okay, we can do ESR, of course it will be raised. We can do CRP and CRP, so of course it will be raised because inflammation is going on. We can go for renal function test, they will be raised, especially creatinine. And we can go for urine analysis. Okay, so urine analysis we can do for that. So of course they will show us RBCs and proteinuria, right? Of course this thing will be there. We can do for now we can go for antibodies, right? So what kind of antibodies? Remember in this one they are ANCA associated. What kind of ANCA? C-ANCA, or what we also call them as PR3. Okay, they will be present. So, and then we can go for imagings like chest x-ray, like CT scan, okay, of the chest especially. You can go for biopsy. Okay, biopsy of anything can be taken, like renal biopsy can be taken, lungs biopsy can be taken, skin biopsy can be taken. So whatever like the areas involved, of course we are going to take the biopsy. Okay, so this one this test and ESR especially, you know, they can also be used to check for the disease activity. If they are high, the disease activity is more. If they are less, the disease activity is less. Okay, so now the important thing over here is what, like simply I will tell you um, uh, anyone who have okay, this is a general concept which you will see in all the, which will help you in treating all the conditions or in answering all the conditions like this. For example, the treatment for this condition. Now see, this is a disease of unknown cause and there is inflammation going on, right? So what we can do, we can give them steroids. Okay, so steroids like methylprednisolone can be given, prednisolone can be given, right? And whenever you cannot give steroids, or whenever the steroids are not working and you have to add some treatment, so you can give them immunosuppressive drugs. So what kind of immunosuppressive drugs can be used? Azathioprine, cyclophosphamide, rituximab, like all these drugs can be used. Okay, so remember guys, this is the general concept for all the conditions, not just this, right? Whenever there is inflammation and we don't know the cause exactly, what is the causative organism, we go in this way. Now if the condition is very severe or life-threatening, you know, we can also consider plasma pheresis. Of course, like plasma pheresis is a urgent treatment which we can go do in the case of crisis. For example, someone who is in renal failure, someone who have pulmonary hemorrhage, you can quickly do plasma pheresis, which is going to can control the condition in emergencies. Okay, so now see, as I told you over here, we were discussing about this one. Okay, a small vessel vasculitis, and I told you the features of small vessel vasculitis. Okay, about Schwartz-Strauss syndrome, like this one, Schwartz-Strauss syndrome. As I told you, Schwartz-Strauss syndrome, this one is nowadays called as eosinophilic granulomatosis with polyangiitis and polyangiitis. So if I will tell you the difference between GPA and this one, CSS or Schwartz-Strauss syndrome, same thing is there. This is, in this one there is granulomatous inflammation, and this one there is granulomatous inflammation, right? But in this one, in Schwartz-Strauss syndrome, there is eosinophilia. And what we found in the tissues is eosinophilic infiltration. And simply when there is eosinophilic infiltration, remember eosinophils are connected with uh, asthma, with allergies. So they present with more signs and symptoms of allergic rhinitis or asthma. And this one is associated with CNCA and this one is associated with PNCA or MPO-NCA. Okay. So rest is almost the same things, you know. So remember like the differences between eosinophils in this one. So anyone who have Schwarz-Strauss syndrome, they present with allergies, they present with asthma, okay, and this is one of the cause of late onset asthma, and it is difficult to control. So the treatment remains same and everything remains same. We are not going to uh, change the treatment things, okay? Okay. So what we were discussing small artery uh, condition, right? Small vessel vasculitis. Now I will talk about a condition which is a medium size vessel vasculitis or medium. Okay, the condition I'm going to discuss in a little detail is called as polyarteritis nodosa. Okay, now it is a medium vessel vasculitis. Okay, like see this one. It is a medium vessel vasculitis, polyarteritis nodosa, PAN. And this one, what are the features of as a whole? Like no matter what kind of medium vessel vasculitis you are talking about, how these patients present now, the medium sized vessels are involved, so they mostly present with uh, Raynaud's phenomena. They present with livedo reticularis. They present with erythema nodosum. They present with nodules. They present with digital infarcts. They present with ulcers. Okay. So, I will show you what is erythema nodosum, right? Though you guys had done dermatology, but okay, this is how erythema nodosum look like. See, it is mostly present on the legs, okay, and it present like this way. So you'll see like all is erythema nodosum, and there is one more thing called as erythema multiforme. Okay, so basically what happened is like this one is a painful type of lumpy rash, which is present in the mostly the lower limbs. Now, if we will talk about polyarteritis nodosa, the points which we are going to cover in this one is um, it is a medium-sized or medium vessel vasculitis, right? And these are the features which are generally present in medium vessel vasculitis. Now, one thing, polyarteritis nodosa is ANCA negative. Okay, like ANCA is not present in these patients. And most of the time, this one is associated with, many of the time, you can say, not most of the time, much of the time, with hepatitis B infection. So all the people who have hepatitis B infection, they may present with polyarteritis nodosa. Okay, males being more affected than females. Okay, what is the criteria of polyarteritis nodosa? Maybe I can found it on Bing. So let's see, like if we can found it on Bing. The criteria for diagnosis. The criteria for PAN, polyarteritis nodosa. So, okay, so you can see over here uh, like here. Okay, yes, we can found this thing. So okay, now this is the diagnostic criteria of polyarteritis nodosa. Okay, you can see like anyone who have a lot of things that they are talking about. Uh, Guys, I don't know what's wrong with my PC, but really. Okay, anyhow, like it's a long list, you can say. Which have like weight loss, which have myalgias, we have libido reticularis, which have neuropathies, which have even testicular pain, uh, high blood pressure, uh, high creatinine, positive hepatitis B, okay, and aneurysms and biopsy evidence of these conditions. So you can say there are a lot of things, Oh, by the way, I can write down here the criteria. Like it is basically, I will just write down the things which are there. For example, they say like anyone who have weight loss of more than 4 kg, anyone who have myalgias, okay, uh, anyone who have uh, libido reticularis, okay, and anyone who have neuropathy, anyone who have testicular pain, um, hypertension. Okay, basically in hypertension they say like the diastolic blood pressure should be more than 90. So elevated creatinine or blood urea nitrogen, hepatitis B, uh, arteriographic abnormality means basically aneurysms, right? And biopsy findings, for example, presence of granulocytes or mononuclear lymphocytes, leukocytes in the artery walls. So anyone who have 3 out of these 10 are present, they say like the criteria is met. Okay, so simply what happens in these patients is like there is necrotizing type of inflammatory lesion. Okay, in polyarteritis nodosa there is uh, necrotizing ne- necrotizing inflammatory lesions. Okay, okay, not in just medium but even in small as well. So that's why when there is necrotizing inflammatory lesion in the medium and small arteries, what happened, like they present with thrombosis, they present with aneurysms, they present with dilatation. So most of these patients, of polyarteritis nodosa, they complain of these things. They complain of abdominal aches, okay, pain in the abdomen, and things like this. So simply, uh, once the diagnosis is confirmed, guys, what happened? Like we go for the treatment, and what is the treatment even for this one? Okay, the investigations will remain somehow same. Like there will be no difference. See, we can do CBC, we can do ESR and CRP, we will do renal function test, right? Like and I think now, like by now, you must know why we do renal function test and why we do all this one, because they all affect the kidneys. We can do the antibodies, okay, and we can, in this one of course we can do the hepatitis serology, okay. Now in this one of course, like it affect the vessels and it can cause aneurysm, so you will go for angiographies, okay. You can go for biopsies, of course, like biopsies we can make the diagnosis on biopsies, right, in these patients, because the biopsies will tell you that there is necrotizing type of the inflammation is there or not, right? So again, how we treat it, treatment remains. See, we don't know the cause. We know that there is inflammation going on. We cannot do much about that. So of course, like we start with steroids, like prednisolone and what you can say. methylprednisolone or all this one, if cannot like withstand, or if there are side effects, or if someone cannot take steroids, then immunosuppressive drugs. And again, like immunosuppressive drugs, I name again and again: cyclophosphamide, azathioprine, tacrolimus, all this one can be given. And of course, in this one, treat the hepatitis B infection. Okay, so of course, like hepatitis B infection, we treat it by giving ribavirin with interferon. So see, that's what happens in these patients. And so we had discussed like one of the small and one of the medium, and now I'm going to discuss one of the large vessel vasculitis, which is I'm going to discuss giant cell arteritis, or what we also call it as temporal arteritis. Temporal arteritis. Okay, so arteritis. So this one is like giant cell arteritis or temporal arteritis. Now this one is large vessel vasculitis, right? And other large vessel vasculitis which I show you is Takayasu's. I talk about that, and Behçet's disease. Now, giant cell arteritis, guys, it's again a very, very, very interesting condition. And this one, like to tell you, if you'll ask me the importance, so I will say like all the things which we have covered now, this is the most important one. So GCA, giant cell arteritis, you can see over here. Okay, now in this one, by the way, there is so giant cell arteritis. If you will see over here, now see, here you can see the temporal artery is quite visible, right? And you will see over here, they are showing you again a lot of biopsies. Number one, they are showing you someone who was having headache, and they are showing you some retina photographs. So see, and they are showing you the temporal arteries, right? So I always show you this thing just to make you remember the things, right? So you can see like, the things which are, which Bing is showing you. And see like here they are showing you that giant cells are present and lymphocytes are present, right? So, okay, a very good photograph, but leave it. I'm going to talk about this condition. So giant cell arteritis or temporal arteritis, they are the same things, first of all, right? And to talk about this one, as I told you, this one is the most important condition which you have covered. Now, first of all, I wanted to tell you one thing, that giant cell arteritis is associated or related with one more condition called as polymyalgia rheumatica. Okay. The short form of this condition is also called as PMR, polymyalgia rheumatica. Okay. So polymyalgia rheumatica, you will find it is written in your books. Okay, maybe not with giant cell arteritis, but they are polymyalgia rheumatica is associated with GCA. Basically, 15% of patients who have polymyalgia rheumatica, they will develop GCA. And as you know, as you can see over here, it is polymyalgia. So simply they have multiple muscles, pain, and weakness and stiffness. So they don't have weakness, sorry, they have multiple muscles, rheumatica is there. So pain and stiffness is there. So they don't have weakness, rather they have stiffness. Okay. So again, there is a classification criteria, or you can say there is a diagnostic criteria for these patients, and this one is more common in females, 2 times more common in females than males. And it occurs mostly in old age, okay, above 50. Now, simply anyone who have polymyalgia rheumatica, they have the same symptoms like fever, weight loss, malaise, pain, stiffness, okay, and all these things. So, they have something called as gel phenomena. Like whenever these patients, they are inactive for a long time, then they have more stiffness. Okay, so remember, rheumatic conditions, they give more pain or more uncomfortableness after a period of rest. This is very important. Now, why I told you this thing, because of course we are discussing giant cell arthritis, but I told you many people who will develop this thing, they are going to develop GCA 15% of the time. So this one, uh, these two are related conditions, okay, and sometimes they are also considered as separate conditions, but because many people of this condition develop this one, so they are, you can say, very much interconnected. Okay, now what happens in GCA is, the importance of GCA. It is the most frequent type of vasculitis in North America. So that's why it is important. So patients are more than 50 years of age. Okay. And female to male ratio is 2:1. So I'm talking about these two. They have the same thing almost around, right? Now, remember, it affects the extracranial arteries. Okay. It affects the extracranial arteries. Okay, the diagnostic criteria or the classification criteria says, like, when the age of onset is more than 50 years, anyone who have new headache, anyone who have temporal artery abnormality, like, of course, like when we palpate the temporal artery, they feel pain or there is tenderness over that area, and they have elevated ESR. Now the ESR in this case is very, very, very high. So basically you can say equal to or more than 50 millimeter per hour. And anyone who have abnormal artery biopsy, I will show you the biopsy. So we need just 3 out of these 5 to make the diagnosis. Okay, we need just 3 of these out of 5 to make the diagnosis. Now, when we talk about the clinical features of this condition, how these condition present. So signs, symptoms, or clinical features, simply how this condition present is again very interesting. Like, these are the patients who present with headache. Okay, headache over temporal region. Okay, and when we examine them and you touch their temporal region, they feel more pain. They have tenderness. Okay. Now the bad thing is what about this condition? Like this, because they have inflammation of the temporal artery. So this inflammation of the temporal artery can also involve the occipital artery. Okay. Plus, the bad part is what? Like, these patients may have sudden painless loss of vision. Now, this is the most important point in this condition. What happens is, basically there is narrowing of the ophthalmic and posterior ciliary artery. Okay, so posterior ciliary artery is more commonly involved than the ophthalmic artery. It can affect even both eyes. So any patient who have headache over temporal region, they are at risk of sudden painless loss of vision, either in one eye or either in both eye, or they can present with sudden painless vision of one eye or both eye. Now, they also present with tongue and jaw claudication, which means like they have pain while chewing, while eating. And many of them, they have the features of PMR. What is PMR? Polymyalgia rheumatica. So they present with, muscle stiffness and pain and all this fun. So many of them, they show the features of this thing as well. Sometimes they also present with aortic arch syndrome. Now, what is the aortic arch syndrome? Simply, the aorta give rise to subclavian artery and the brachial arteries. Okay, brachial branches as well. So whenever like these branches are involved, so they present with pulseless. Okay, pulseless. So they present as pulseless disease. Same like what I told you about Takayasu arthritis. So also they can have aortic aneurysm. Okay, of course, like when there is aneurysm, so aorta can rupture anyways. And rest are general symptoms like shoulder or hip pain, okay, or pelvic region pain, you can say, and stiffness simply. These are the constitutional symptoms. So, like, these are all the features, but remember, guys, the most important thing is this one, okay. Okay, guys, this one is a clinical diagnosis which can be confirmed on uh, you can say like this diagnosis is done on clinical suspicion with increased ESR. When we check their ESR, it will be increased ESR. Okay, once we get these two things, the diagnosis is almost done, right? We can also go for temporal artery temporal artery biopsy. We can also go for ultrasonography. We can also go for MRI, like again to check for the areas which are involved. So now the most important point to discuss in this condition, like what I wanted to talk about, is the treatment of this condition is very important, and many of the exam questions, especially steps and blab type of exams, they ask questions from this one. Remember, guys, it's a medical emergency. Why medical emergency? Because it can lead to blindness. That's the important thing. And many people, they become blind because of this thing, right? Many people, they become blind due to this thing. So that's why anyone in which we even suspect GCA, start them on high dose prednisolone or prednisone, depending on where you're working. Okay. So basically, how much they give like is 1 milligram per kilogram, simply. Okay. And it is continued for like around 4 weeks, or you can say 1 month. See, it's a very high dose steroid for a long period of time, and then we taper off the dose. Okay. And this is the treatment which can prevent blindness, remember, or other vascular complications. So remember this thing. And after that, you can say consider low dose acetylsalicylic to help decrease visual loss. Okay. So this is like how we treat this condition, and this is how this condition behaves. So that's all, guys, for this vasculitis part. And of course, like there are other vascular conditions as well. And I did not talk about everything. I talk about I talk about almost Kawasaki Becher's disease. Okay, Becher's disease, again, it's a vasculitis of unknown etiology, and you can see like they have written as like large artery vasculitis. Okay, so what happens in these patients is basically they present with a triad. They present with a triad of you can say they present with a triad of I think so. Okay, I will tell you now. Okay, basically they present with oral ulcers, and they also present with genital ulcers. Yes, so it was something like this, that a person who cannot pee, who cannot see, and I read somewhere, about this condition. Like there's a mnemonic for that, but it's not coming in my mind right now. Okay. So basically, they present with oral ulcers. Some of them they present with genital ulcers as well, and they present with erythema nodosum, and like these are the features they present with. So, and many of them they have ocular involvement as well. Okay, which is a uveitis. It was like something like this: a person who cannot eat, cannot see, and cannot pee. Uh, you can search I think when you search Behçet's disease on internet on Google, because I cannot access Google right now. So that's the problem with me right now. Behçet's disease, like maybe we can found a mnemonic for that. Yes, maybe we can found. As far as I know, it was something like this, a person who cannot see, cannot I read it many times. Here he's talking about mnemonic, but um, see, yes, oral ulcers, genital ulcers, uveitis, right? It was something like this: a person who cannot pee, cannot see, and cannot eat. Okay, but not in this sequence. Rather, it was easy to remember. So simply remember they present with genital, with oral, and with eye problems like uveitis, and some of them they have neurological involvement as well. Just very few of them. So anyone in which there is Behçet's disease, okay, or Behçet's syndrome. So what happens there is a criteria for that with oral ulceration, with genital ulceration, with eye examination. So in eye, of course, there is not just uveitis, rather there are many other things, and we do a test called as pathergy test or skin test. It's a type of skin test in which what they do they intradermally they prick with a needle, and if within 48 hours there is a pustule over there, they make the diagnosis of Behçet's disease. So this is how this one present, right? Rather others, we already talk about all of them, right? So that's all about this vasculitis. I will see you next week. Thank you so much.